Hi, good evening, everybody. Welcome back to another session of our webinar. And this is our last segment for the year, where we have 4 CPD points to be given out, courtesy of Sunway Medical Center. And I have here with me Dr. Rosmadi. Dr. Rosmadi, of course, was one of the respiratory physicians who was actively looking after COVID patients. So he's here to share his experience and tell us more actually about COVID and respiratory system. So without much ado, we invite Dr. Rosmadi to give the talk. Rosmadi?
Hi, everyone. Thank you, Betty, for a kind introduction. I think initially when I was invited to give a talk on COVID, it was something like I thought that COVID has been on everyone's mouth for the past 2 years. It's kind of, I mean, everybody can find just Google and probably have plethora of informations. People been talking about it. It's in the news, it's in the radio, it's in the TV, COVID. I was like, probably like, I was just not something that, because it's everybody, I mean, it's in every domain and you can find a lot of things. But when I try to prepare for the talk, I found that there's a lot of unknown rather than what we known so far. I mean,
exactly, yeah.
And I hope I don't confuse everyone at the end of this, but I have to make disclaimer that at the moment, even though we have been in the pandemic for the past almost close to 2 years,
True.
there are more uncertainties than what we are really know about COVID. We thought we know, but actually we don't. Okay. And I've been treating COVID close to a year since the initial 1 year kind of because there are not many, most of the patients are treated in government center, but since January this year, most of the private medical center has been actively participating in and actually treats a lot of COVID patients. And being a resident, we are probably treating the sickest of COVID patients. So because there are not many, in government, probably there's a lot of infectious disease specialists, but in private, there are not that many. So inevitably, majority of the ill patient will be treated by the respiratory as well as by the intensivist and few of the infectious disease specialists. Okay, so if you are going, go to the COVID webinar in Malaysia, probably in the past a year and a half, probably it will be dominated by the ID specialists because they are probably the first who treat the COVID in the country. Okay, so but I think as the disease went on, everybody got fatigue treating COVID non-stop, and which is quite relentless. I think probably now the condition is a bit better. Hopefully it will last long, but from the pattern what we are seeing at the moment, probably it's gonna stay with us for quite some time in the future. I mean, we hope that it will go away, but unfortunately, I think COVID is here to stay. So, and I said, even though it's been here for close for 2 years, I can tell you that majority of the expert in the world, especially in the lung point of view, we are probably don't know more than what we know. Okay, so so I'm going to share a bit some things. Hopefully you will help for the probably the audience are varied from younger doctors and probably some those in the specialists and non-specialists. Hopefully, I try to make it simple. Okay, the slide has some detail, but I probably won't be able to go through all of them. Okay, I just need to answer the call. So I'm on pause. You know. Okay. Okay. So I'm just gonna, as I said, I'll try to be a bit more basic and try to make things easier to understand for the non-respiratory doctors. Okay, so this is our agenda. I'm going to start with some introduction about COVID. What is COVID? Acute lung injury, which is, and then on and the plethora of acute lung injury in COVID, and then the challenges in management during the acute phase, as well as post-COVID, which is what we have to deal with at the moment. Okay, so I'm not gonna go into how we're gonna treat, because I think our Malaysian guidelines and a lot of guidelines on COVID management out there and easily accessible. And then I think I will share some cases. In the cases, there will be some information on how to treat COVID as well.
Oh, that's great.
Yeah. And okay, let's go to the introduction. As we know, COVID stands for coronavirus disease, and because it was first detected in 2019, that's why it's called COVID-19. It's caused by the novel coronavirus. We have a human coronavirus. There are several types. So early in the course of disease, even when I put there, I mean, we have some human coronavirus detected in our PCR test. We put coronavirus, the whole hospital like come to the ground and say, why you put coronavirus infection? I say, look, this is not COVID. This is human coronavirus, which is fairly common. Okay. But I think over the past 1.5 years, we learned more and more about it. We are not, I mean, we didn't say that we didn't scare. I think we learned how to deal with it. Okay. So as it's a public knowledge that it was first identified in Wuhan city, and we know that a lot of media out there say that it might not be originate from there. It could be from Europe, and it could be a biological weapon. I don't know, right? It might be true, it might be didn't, but what we know so far, it was first identified in Wuhan city, Hubei, China, and it was reported to WHO by the health authority in China in 31st December 2019, hence COVID-19. And it was declared pandemic on March 11, 2020. And till today, there's multiple new variant has emerged, and it sustained the pandemic until today. Okay, it may be going to endemic. I mean, soon. Okay. So here's a pathogenesis. Again, this is a public. I mean, though in the public domain, we know the reason we call it corona because it looked like because of the spike protein outside of the virus. Okay. So this spike protein are very tricky and sneaky because the spike protein, there's a name for the spike protein. They are locked into the ACE2 receptor, and then courtesy of this trans protein membrane, it basically is just bring the virus in. It locked to the ACE2 receptor. And then there's a process called endocytosis, and unlike bacteria, bacteria, they are causing infections, they don't have to go into cellular. Okay, so the COVID virus and most of the virus, they go into intracellular. Basically, they take control of the cell, and then it's the cell so-called becomes zombie, and then they produce more virus, and the virus trigger pro-inflammatory cascade, and at the same time it causes a plethora of side effect that we know so far. Okay, and this process, the endocytosis, and basically when we learn biology in our medical school, where they take control and then they use the cell mechanism to produce more virus. A lot of virus later on will cause cell damage, and it release, and probably one infected cell will produce millions of virus, and then the process, and then when the cell release or rupture, it produce a lot of pro-inflammatory cytokine, and this is the reason that we probably see in a lot of severe COVID. Okay, so fortunately, majority of the COVID mild or asymptomatic, okay, and about 20% may require hospitalization, either because they are having risk factor that we already identified, which is listed below, like we have male sex, older age, hypertension, obesity, diabetes, people with lung problems. Okay, so and out of, like, let's say 100 people got infected, 5% will become critically ill. Even though there's 5% of them, but if you have a population of 1 million, that's already caused huge burden if all of them got infected of this, at the same time. So that's hence when we have we say that flatten the curve. I mean, eventually a lot of people will get infected if we don't get vaccinated. Even those people with that are vaccinated will become infected, but if they all become infected at the same time, the health system will be put into stress, like what happened in Malaysia in the months of July, August, and probably early September. Okay, so we know that apart from all the risk factor that listed here, we also know that there are some probable host genetic factors that exist. There's a lot of people are diabetes, they are doing well. There are some people with diabetes doing, even though same age, same risk factor, but some do really bad. And there are some theory that say that it probably due to some HLA typing of individuals. So apart from this risk factor, there are some probably genetic factors that we don't know, causing why some people have more disease than the others. Sorry. So in the term of pathophysiology, okay, COVID will cause, we know, some epithelial or alveolar damage, cause hyperinflammation. At the same time, it causes probable nosocomial infection, either due to the infection itself or due to the treatment that we give to the patient. And it can cause multi-organ failure, and the consequences, I will go on a bit more detail on this, is structural lung damage. This lung damage may be reversible. In some patients, small percentage may be permanent. Okay? So COVID is a bit more tricky than other common virus like your influenza virus, because we found that apart from causing this alveolar damage, they also can cause endothelial damage, which is why a lot of there are some patients, especially in the post-mortem study, show there's microvascular thrombosis, and not just in the lung. There's also occur. Sometimes patient may develop stroke, develop myocardial infarction. This is of the microvascular or endothelial damage that causing microvascular thrombosis, and then this can lead to bigger vessel thrombosis. Okay? And all this, I think you quite familiar. Sometimes our COVID patient may presented with high blood pressure. Sometimes they will have stroke. Sometimes they have myocardial infarction. Sometimes they may develop pulmonary edema because of the leakage of fluid into the alveolar interstitium. Okay, so this is a schematic diagram, and I mean this is one of the theory. What happened in COVID in the early stage? They cause some innate and also adaptive immunity response. Okay, and in the early phase, in this, they could also in the severe stage, causing diffuse alveolar damage. And so basically, there's a cartoon is hyaline membrane is equal to diffuse alveolar damage finding histologically. Okay, and this is a bit more by another author, by Gastain et al., showing all the possible cytokines that are released when remember that the infected cell they got damaged, okay, and they produce a lot of pro-inflammatory and some damage that I probably go through a bit in the next slide. Okay, so this is probably this is the theory. Okay, some of it are what we know quite accepted. Especially this is called the Penta Loops, the 4 loops of COVID infection. First, we call it viral loop. So when they invade a cell, okay, it causes a lot of pro-inflammatory reactions, like the one that we showed earlier, and then this cause things in the hyperinflammatory loop where more cytokines being released. When infected cell, when cells are infected with COVID, they either there are 2 pathways. One is called apoptosis, it's a programmed cell death. So we have a mechanism to so that the cell will go to their eventual death, and all the I mean the virus will die with it. But the other way that they can enter is called a pyroptosis. Imagine this like a kamikaze. Basically, the cell will produce more. And during this pathway, they are basically releasing more cytokine. This is the one that trigger your cytokine storm. Okay, so if this is happen continuously like a loop, and this is like a vicious circle. Other thing that the viral does, so it upregulate the ACE angiotensin receptor. I think the cardio and the renal know about this a lot. So it regulates our blood pressures and a lot of things. And ACE and angiotensin cause a lot in the lung, in the upper and lower respiratory tracts. So, and as well in the endothelial vessel of the lung. So they call it RAS axis loop. So what happened is the other component of, I mean, when we have the upregulate angiotensin 2, so what happened, they will cause high blood pressure. So sometimes when we have COVID patient that came in with high blood pressure, this is because of the viral replication causing this. And this thing also interesting because the other little known about this Rosmadi loop. They also involved in the formation of fibrosis in the lung. Okay, so the other loops that the virus would do is we call it hypercoagulation loop. So basically, endothelial systems, at the end of the day, it causing platelet dysfunction and also causing thrombin generation. This probably controversial. Maybe said it could be easy because of the diffuse alveolar damage, causing endothelial damage and causing this platelet dysfunction as well as microvascular thrombosis. So all these at the end of the day will cause diffuse alveolar damage, acute lung injury, ARDS, uh, and it is quite vicious. And if a patient doesn't get treated, so there's, as I mentioned, there are some people who have some predisposition, genetic predisposition. Even whatever you do, they still progress to all this bad complication. Okay, so the cause of COVID, I mean, this is not, I mean, put here stages of this COVID infection. We have stage 1, 2, 3, 4, 5 that we know those people treat COVID, but this is more of the stages, not a clinical stage, but a clinical, I mean, this is more of, we're talking about infections. So stage 1, which is the asymptomatic, which is your innate immunity, okay, and then the non-severe stage, which is in the early part of infection, and when the viral count drops, when you're in the probably after day 7 and 8, where you have some people, this 5% of people, to go into the acute severe respiratory problems where they have cytokine storm and all this. Okay, so the diagram on the right side, it show their potential treatments in the every stage of the disease. So the viral phase, the initial phase, will cause more of the innate response. In the middle part, probably day 3, day 4, and 5, where this is more of your adaptive immune response, and then maybe now the antibody that will produce attack your own cells, because remember that the COVID are intracellular organisms. Okay, so now your own cell are being attacked by your own antibody. So that's why, this is quite vicious. So understanding this is crucial because you will understand the lung response to injury of COVID, and then where the patient condition at that time, so you can intervene um, correctly. And so not all patients, when they came in, you give steroid. Okay, maybe the early part the steroid is not good because it could impair your innate immune response. But later on, when your immune system on the hyperdrive, you need that to suppress all the inflammatory response. So, and then when you have some overproduction of cytokines, so there are treatments. So now we have some there are few medication that we can use in the early part, also in the later part of the cytokine response. So it is very important to know where is the patient so that you can give correct treatment, and then probably determine what are the post or the sequelae of infection that will happen to the patient. Okay, so for example, by understanding this, you will know, you kind of know what, I mean, we order a CT scan. If I order CT scan, that patient are in category 2, I'll know how the lung will look like. Okay? So if someone in category 5, even before the CT scan come up, I can tell you, okay, this what happened in the lung. So for understanding this, the process is important so that it will help you to determine what treatment to give, as well as what are the expected of the outcome of the patient when they recover, or if they don't recover at all. So you can okay tell either the relative and what to expect. Okay, so lung response to injury are predictable. So what I meant is there's only things when anything that injure the lung, either noxious gas, either a viral infection, either aspirated food particle, there's the injury to the lung are predictable. Okay, so and then the response to injury are limited, despite all the thing that can cause damage to the lung. Okay, so usually when things cause harm to the lung, our lung will respond with some organization. So there are some injuries, there's some response. For example, there's some probably um, response that are appropriate to the amount of injury to the lung. Okay, so and it's as I said, they are limited, and it's can be expected. And the thing is, what we don't know, especially in COVID, whether which pathway that they will become, either the lung from that injury will turn into just organizing pneumonia that can be easily treated with steroid, or either they are going into non-stop formation of fibrosis that later on become a fake fibrous lung tissue. Okay, so the response of lung injury, as I said, there are few patterns. First, we call it organization phase, which is diffuse alveolar damage, and then you go to organizing pneumonia. And there's also a thing called acute prevenous organizing pneumonia. Means that the moment that it develop organizing pneumonia, it develop acute fibrosis. This is usually responsive to the 2 and 3 are quite responsive to steroid, and the fibrotic stage they are usually don't respond to your steroid. And there are fifth component, which is things called eosinophilic pneumonia, which not involved in COVID. Okay, so what is diffuse alveolar damage? I mean, if you those who treat COVID, you'll always see a report in the CT scan, the diffuse alveolar damage. But historically, it's a diffuse alveolar damage is the histological term. We call it diffuse. Does not mean that involve the entire lung. It diffuse because it's involve all layers of lung parenchyma. You got lung tissue, you got alveolar basement membranes, and you got the endothelial linings, all that involved. So that's why we call it diffuse. So it's not meant they involve entire lung. So there are probably small patches of lung involved, but they are diffuse alveolar damage. And it's a histologic term, but I guess and a lot of people say that diffuse alveolar damage equal to ARDS, right? But diffuse alveolar damage can happen in non-ARDS, and there are some ARDS that occur without diffuse alveolar damage. So, but in case of COVID and other infections, a lot of times in clinical round, when we say diffuse alveolar damage, it means very bad, and if it usually involves the entire part of the lung, and usually it's, the patient are in the acute respiratory distress syndrome, or ARDS. Okay, so but historically, it's a histologic pattern. So you need to biopsy the lungs. But in the case of COVID, very severe COVID, nobody would dare to to biopsy the lung, so just to show that this is diffuse alveolar damage. So that's why I think in the past when they biopsy a segment that look with certain finding in the CT scan, and the finding are similar to this diffuse alveolar damage pattern. That's why nowadays we accept that finding in the CT scan report. Okay, so this is what I meant by diffuse alveolar damage finding in the histology. This is not a COVID patient. Okay, so you have the arrow is the hyaline membrane, which consists of dead cell, the surfactant, and the protein. And you can see the star is the lining of the alveolus. Okay, so this hyaline membrane covered the entire surface of the alveolar, and then it impaired the oxygen exchange. So in the end, the oxygen, even you give a lot of oxygen, they say still cannot diffuse. Okay, and later on, if the thing progress, they will become organizing fibroblastic tissue. Okay? So this is the lower picture that show that all the alveolar cell or linings become fibrous tissue. Okay, so normal wound healing, I mean normal injury with appropriate response, majority will undergo a normal tissue repair. However, there are some aberrant wound healings which trigger.
You put hand all over. I put hand.
You put finger and hand wrong.
Okay, go
Yeah.
on.
Okay. Sorry. So, which later on, and we, as I said, we don't know. Okay, which one, either which virus that trigger fibrosis. Okay, so there are a lot of variations. So, I will show later on what factors in COVID that trigger a lot of this lung fibrosis. Well, or is it really COVID, severe COVID at the end of the day will develop lung fibrosis? Okay, so this is a histology pattern of someone with severe COVID that are and the patient died. So this is the patient that are the very severe, and on the right hand side, which is produced by Ackerman, which show a microthrombi. This is probably one of the early histology finding that show, look, COVID, there's a lot of microthrombi. You need to treat patient with anticoagulants, so to prevent a VTEs in patient with COVID. Okay, and on the left hand side, the picture showing histological, showing a lot of this hyaline membrane, a lot of diffuse alveolar damage. So, but this is not happening in all patients. This is a autopsy patient where they are extremely severe patient that are died from COVID. Okay, so it doesn't happen in most patients with COVID. Okay, so this is a diffuse alveolar damage pattern in patient with COVID. So this is not just diffuse alveolar damage, but it's also involved probably the entire lung. You have this ground glass, and then you have some septal. So you can see that this is called septal thickening. Okay, and then you have a lot of secretions that causing a gravitational gradients or dependent consolidation. This is probably not a pneumonia. This is more secretion that settle in the lower part because of the gravity, lower part of the lung. So if we know a bit of anatomy, okay, this is the reason why we do prone ventilation. Majority of our lung is at the back. Okay? When they are they are lying on their back, so majority of the lung will have a lot of this secretion. So that's why when you do prone ventilation, the secretion accumulate more in the front part, which is the probably the lower surface, lower amount of lung. So when during prone ventilation, more lung tissue are liberated by the secretion and they will breathe better. Okay? It does not cure the lung, but it's just buy you sometimes give your treatment. So and then when you get better, you can put back the patient on their back. So that's the use of prone ventilation to liberate more lung tissue, which are predominantly at the back compared to the front. Okay, so not all consolidation are pneumonia or organizing pneumonia. So when you prone them, it become clear. So this is not really a pneumonia, is more of the secretions that accumulates in the alveolar. Okay, so what is organizing pneumonia? Okay, so it's a non-specific lung injury response, and it's also a histological diagnosis. Okay, so you will have compared to hyaline membrane, you don't have that in organizing pneumonia. Okay, so the thing that I mean, I don't want to go to detail on this organizing pneumonia, but you need to know that it usually can get better on their own. However, majority of the time, this process, the recovery process, can be made quicker by the use of steroids. So that's why steroids are used, especially in the patient with post-COVID organizing pneumonia. Okay. As I said, and then the radiological changes in OP are heterogeneous and they are non-specific. So I just put up some of the findings that can be called OP, but this is not just unique to COVID. So this is just OP in general. So you can have consolidation, this called reverse atoll sign. Atoll is still around. He is probably one of the experts in interstitial lung disease. So you have in the center part at less wide compared to the outer part, because this was you get reverse halo sign. This is a reverse atoll sign. Okay, and then there is perilobular. Remember that it's lobule septal, so you could have some consolidation like at the perilobular area. Okay, and you can have some multiple nodule, and you could have some subpleural. This is pleura, the area behind, just behind it or just above it, we call it subpleura. Okay, so oftentimes because it's non-specific, and plus in someone with COVID, they will be mad to biopsy the lung because you can trigger even more inflammation. Okay, it could trigger when you biopsy the lung can cause I mean there's pneumothorax, so it will be not possible in in most cases. Someone that already come with COVID and they probably nicely recovered or not that bad, you will be kind of insane to biopsy just to prove a point. Okay? So that's why this kind of thing should be resolved in the multidisciplinary discussion or meeting. Okay, so it will be good. I think it's common in government practice. So where there are some the chest physician, there are radiologists, some RD experts. The good thing is the RD expert in the world, there are not many, but they are strong. I mean, we in Malaysia, we have a few RD experts and we have regular discussion with the expert from all over the world. So you just need to get the right person so that probably a difficult case like this can be discussed. Okay, so so as I said earlier, COVID It's just something that causes injury to the lung, but you need to understand the pattern. So it's this Nicholson et al. Has said that the lung pathology is an old pattern in a new clothing. This is called COVID. So it's just that we still don't know when it will happen, who will have severity, in which pathway of the lung damage, in which pathway of the recovery that it will take. And I'm sure there are some genetic predisposition to, because as I said, the people with the same background, the cause of COVID are remarkably different because there are many factors. So, and the interesting thing about COVID compared to other viruses, the COVID pneumonia tend to occur a bit longer compared to the usual influenza pneumonia or other viral pneumonia. This long course of COVID pneumonia, I believe, make things more unpredictable because remember that something acute that will go away, make the repair faster. But if you think it happened more, longer or repetitive, so it will probably cause more damage. Okay, it involve more system, not just the respiratory. Um, and at the same time, as I said, some of my patients develop multi-organ failure or dysfunction because of the COVID infection, not just confined to the lung. Okay, so this is just going to discuss what happened when you have acute infection. So apart from COVID, okay, we also can have super infections to your patient. Okay, so this is first case of patient, one of my patient, where came in with severe COVID-19 pneumonia. It was quite early in the course, and where we use dexamethasone. Okay, it was given tocilizumab as well, and then because it progressed on dexamethasone, it was given high dose methylprednisolone. So with the intention to arrest all the damage, the inflammation from the COVID infection. Unfortunately, when we suppress the immune system, patient you can see ventilated. Patients has a secondary infection because it's ICU. It's developed multi-resistant Acinetobacter infection, and patient succumbs to the secondary infection rather than COVID. You can see that there's some improvement in the lung. Previously, the ground glass that's improved, but the patient become there's more severe, there's no pneumonia, and I think the patient succumb on day 30 of hospitalization. Okay, the second case, which is younger female, came in also with severe pneumonia, was given immunosuppression, DEXA, as well as methylprednisolone. Okay, and because in ICU again got MRO Acinetobacter, but because she is young, she developed improvement from the COVID as well as the secondary bacterial infection. However, she developed pulmonary aspergillosis, which occur at week 6 of hospitalization. So she haven't go back at that time because she require a lot of oxygen. So and with regard to the fungal infections, I know probably some of you may heard that there are increasing case of fungal infections. Those people with COVID in India, it not just happen in India, it also happens in our country. Probably we don't really have the black fungal. So I've seen several of my patients develop aspergillosis. I have one patient or few patients that develop PCP, which is pneumocystis urobacillus infections because of prolonged use of a steroid. So this is become very tricky. I mean, patient improve initially from COVID, from the steroid you give them, but because of the steroid, patient immunity reduce and they can develop opportunistic infection. It can be aspergillosis, it can be candidiasis, or it can be pneumocystis urobacillus what happened in my patient. Okay, so we go to the spectrum of disease post-COVID infection. So we after the acute phase, okay, so you can have prolonged COVID. So it could be due to the sequelae of the lung damage, or it may not be due to damage at all. I mean, sometimes I have patients where they don't have any changes in the lung, in the CT, they are normal, their oxygen in normal, but they are still lethargic, they're still coughing, and they sometimes may have some upper respiratory symptom, and in a lot of patients presented with symptom called brain freeze or brain fog. So I'm not going to touch into detail, but it's a common thing, especially even patient uh, non-severe category 1 or 2, they develop this brain fog thing. So there's again, there's a lot of uncertainty that the thing that we know, because in this patient, you don't know what causing the symptom, because if you check the blood count, if you do CT scan, if you do lung function, they're all normal, but they have the symptom. So that's called thing called long COVID. Okay, so um, next will be one of the things that are fairly common in if we treat severe COVID. Okay, as I mentioned that think about organizing pneumonia is common after a lung injury, so it's not surprising. But even when I say not surprising, a lot of times most of the OP does not behave like the usual OP, because the usual OP that are not due to COVID-19, we call it cryptogenic organizing pneumonia. They tend to respond to steroid very well, but they need longer duration. So most of the COVID we give either 4 to 6 weeks of or even less duration of steroid and even lower dose compared to the usual cryptogenic. And then the cryptogenic organizing pneumonia, OP tend to recur when you taper down the steroid, but not post-COVID OP. So you can't really call this organizing pneumonia or I think the more appropriate term would be OP-like condition. However, at the moment, they are zero RCT. Most of the time, when patient post-COVID, and then they have some residual lung changes that look like organizing pneumonia, the OP-like picture, we give steroid. And there's no RCT. Or if someone doing it, they haven't published yet. So we have no randomized control trial. Most of the time, they are expert recommendation, and then highly varies. Okay, for those who have treated COVID or been a COVID patient, sometimes we give certain dose that we taper every 3 days, sometimes every 5 days, sometimes every a week, and then so it varies. Even myself, there's no fixed regime. So that's So whether we're doing the right thing or not, most of patients do improve, but we are not sure whether they improve because they can improve on their own, whether they really need that much steroid. Okay, so most of the time we give because then if it happen in the future, the thing lung become fibrous, then we say, oh, I should have given. So by that time it's probably a bit too late because most of, I mean, if they develop a well-organized fibrosis, then it's maybe not reversible anymore. Okay, remember that I tell you that will be crazy if you want to biopsy a lung while you have COVID. And but fortunately, we do have some
Praise
really
people.
brave, really good people out there where they actually do biopsy the lung. So this technique is not a forceps biopsy. They use basically a cryo biopsy. It's a cryo probe that you put into the distal part of the lung and you yank it out and you can get as big as half centimeter of lung tissue. So this is by quality groups. We have probably 2 or 3 people that are trained under him in Malaysia. So we have some very good interstitial lung disease expert in Malaysia that trained by this quality group and is probably one of the leaders in interstitial lung disease in the world. Okay, so they biopsy, but these patients are not the very severe type. They still require the CT scan have some changes. But I guess they're all non-ventilated. Okay, when they biopsy, they found out that there is no diffuse alveolar damage. Okay, most of it, and which is unlike. Remember, I show you the diffuse alveolar damage in the post-mortem lung tissue in in the patient that died from COVID. So this is a fairly mild or moderate category 4 kind of patient and they require oxygen. They do this within 20, most of them within 20 days of illness. Okay, and TSS is a score or hypoxia score, something they use. So there's no diffuse alveolar damage, and then even within 8 or 6 to 20 days, most of the mild cases are the organizing pneumonia types, histologically. So, even, I mean, the, depending on the severity, the histology are different. Okay, but as I said, you can predict what are the possible damage to the lung because as I said, the damage of the lung can only 5 patterns. Okay, but when and who have the pattern would do. I mean, knowing that detail will help you in managing the patient. Okay, so the other things that I would like to talk about is some of the very severe COVID patients. When they recover, their lungs have some residual injury. So this patient probably has some pre-existing lung disease that either very mild or they have the genetic potential that causing when they got COVID, the thing got really worse. I mean, before COVID, they never had chest X-ray done, so they don't know they have underlying lung disease. Okay, so there are even non-critically ill patients. Even when they recover, there are some residual lung damage or abnormal repair. Okay, so and as I said, there are many theories, there are many publication on this. I just put very minimal just to spike interest. So um, uh, so that we'll know that there are many pathways that the thing can happen when someone infected with COVID. Okay, so this is one of the slide that I picked from one of the RD expert. Okay, so there are people from where they don't have very severe condition, they end up with lung fibrosis. And who they are, somehow their risk factor is the same as those people that develop, we call it idiopathic pulmonary fibrosis, which is older age, male, they have comorbidities. So and plus, as I said, at the moment, we know the risk factor, but we don't know which one truly will have this condition, okay, the lung sequelae. So remember that the 5% that become severe or critical require hospitalization, require oxygen. When we follow up 30 to 50% as recovery, they are small percentage will die, and those who didn't die develop pulmonary fibrosis. Okay, so and there are numerous articles about this where people develop even though they are better. And in fact, I have several patients that has changes in their CT scan. Unfortunately, because I'm in the private practice, every time they see you see a patient, they got charged. Every time you do, they pay. And when someone already feel a bit better, they said, I don't need to come and check this again because I'm good. I have no cough. But when you see the CT scan, there are some residual changes. So, but it may not be so severe until it's affected their oxygenation. Okay, so this is um, the other one of the publication. Okay, because you can see when they got this state of illness, their ground glass, there's some diffuse alveolar damage. This is day 79, close to 3 months. Okay, you can see that the fissure become, you can see it become dome. The reason being, the upper part are contracted and pull the fissure up. Okay? So, and these patients are fairly asymptomatic. Yeah? And only in private, they usually say, I'm okay, doctor, I will see you as needed. So most of the time they are lost to follow up. And you can see that they follow up the CT scan for up to 6 months of the time. Okay, so this is China. I think doing marvelous about this. They produce a lot of being the first encounter this and being, I think the way things happen. I mean they can follow up. They probably have some unlimited resource. Some of them. So this is a year after the COVID. Okay, so uh, they are still persistent CT abnormalities, even though they are well. Okay, there are still some of them that the lung function is abnormal. Okay, so believe it or not, we are in this what we will call a tsunami that will happen after the earthquake, which is a lot of us out there, even though they are quite well, they are walking in the street, but they have COVID in the past where they have this that probably we'll see 10 years from now that they probably develop into full-blown lung fibrosis. This is, as I said, it's more question than answers. Okay? So because you are still in it. Okay. So again, another publication about interstitial lung disease, and lots of them. Just going to go very fast here. So because same thing as this publication, by Atto, well, remember the reverse Atto sign, okay? It's say a catalog as uncertainty. So we don't know, okay, what will happen in the long term. Okay? Even a year from post-COVID, we still see some people develop fibrosis even though they are not severe. Okay, this COVID must be triggering something. Okay, okay. So this is another case, which is a 73-year-old former smoker, category 5, intubated, because because of the persistent breathlessness. Okay, but after, even though he's extubated, he's well, he still has some changes in the lung. Okay, so this is the X-ray, and this is the CT scan during COVID, and this is the X-ray. It looks most of the time, for example, my patient will say, okay, I think if you want to see your lung more detailed, you should do a CT scan. But I say, oh, X-ray looks okay, doctor. It looks not that bad, right? But if you like the CT, if you look at here, you can see that this part of the lung, they have become a bit more wide, and the lung volume also contracted a bit. Diaphragm is elevated on the left. You can see that there is a focal of fibrosis. Okay, so this is 2 months later. But I think if we do CT scan few months later, the whiter part will become less, but the lung will become a bit more contracted because of the uh, the foci of fibrosis. Okay, so this is another severe COVID patient. It developed pneumomediastinum. Okay, and this is basically during infection. It's quite severe, quite it's alveolar damage, and then okay, this is the follow-up CT scan. Okay, so as you can see, the part that are involved the most will develop a pattern of interstitial lung disease. Okay, so even though they recovered, okay, this part, but interestingly, several patients that I do, as I said, CT scan, serial CT scan, you see some involvement, but they got better, most of it, but the scar, it happened for not all of them, some patients. I do have patients that are totally, the lung become clear, even after a month of infection. So this is another patient, a lady, 55-year-old, category 4, but it was not on very mild oxygen, okay, because of mild involvement. So 2 months later, you can see that the X-rays still have some changes in the right face. Okay, so when we do lung function test, for those who never seen lung function test, anything above 80% is normal. Okay, but you can see that there are in the lower normal. So because of I think if we do follow up, it maybe will improve. Okay, and there are people who publish a long-term effect on the lung function test. So 3 months post-COVID, majority develop restrictive pattern, which is, I mean, all the interstitial may give restrictive pattern. Interestingly, there are some obstructive pattern. So, which is, to me, is not surprising because I do have patients with mild COVID, but somehow it triggers them to have some obstructive symptom, which is like bronchitis or asthmatic symptom. And they maybe have some predisposing history in the past. It's just that during COVID, it's not a problem, but a month later, they develop same, I mean, like asthma-like symptom. Okay, so and this is the obstructive pattern, the small airway impairment pattern. Okay, so post-COVID, you can develop air trapping, you can develop um, bronchitis. I've seen this quite a lot. And interestingly, it's not just due to COVID. I also see post-COVID vaccination where patients develop some air trapping, some small airway disease. So I'm not sure what causing this, whether the inflammation being triggered by the spike protein. That's why, because they use vaccine using a spike protein as well. Okay. The other things, remember, we are in a country that has a lot of TB. I have patient that came in where probably they went TB first, but there's not much symptom. But my patient developed cough, COVID, let's say in July. I saw him in September. They say COVID, I just stay at home, quarantine, but the cough persistent until, he wait 3 months to see me until he had no voice. The X-ray are full-blown TB with a lot of cavities, and after we treat TB, patient better and got back the voice. Okay, so remember, it's not just the COVID sequelae, it could be like in Malaysia, you need to think that it could be a potential TB. Okay, this is from a slide from the recovery. So I just need to emphasize that even though in the private practice, I do people say it's one man show, but you actually not alone. You can discuss this with your colleague with a similar fraternity. Could always discuss. I got always other respiratory physician will discuss the case as well as I'll talk to my radiologists, especially those who are expert in the interstitial lung disease. So and then discuss to other. Beyond your own hospital. If you are clinic, discuss with someone that you're familiar with. So because you don't have to have the so-called official MDT. Okay, the discussion should be beyond that. So in the private practice, it's maybe it's a bit difficult, but it can be done. Okay, so and as I said, there's a lot of uncertainties still in COVID. What will happen a year from now, 2 years from now, we don't know. Okay, so I think this is my last slide. Okay, so understanding the cause of disease is crucial in acute as well as post-infection, and then it needs to be managed from where the patients stand at their disease. So understanding the cause of disease is important, and then the follow-up. I think probably 3 months is not enough, but I think in private practice may be a bit difficult, especially if patient is they are well, but you could convince them. If you can't follow them, you can always refer to a center that has post-COVID clinic. Okay. Remember that those severe patients may have lung injury or lung fibrosis. Okay, and another thing is multidisciplinary. Discuss with others so that patient can have the best of treatment and better outcome. Okay, that's my last slide.
Okay, thank you very much, Rosmadi. If you can stop your slide, maybe I can share what they've been waiting for. Let me just share the QR code. So basically, okay, just let me explain the QR code. You must be watching from the laptop to scan the QR code with your phone. So your phone, you go into the MMA app and just scan it. It's quite easy. But if you, for any reason, can't scan the QR code, please send me, I've given you my phone number, send me your name, IC, and MMC number, and email all in one message on WhatsApp. We will do it, we will do it manually for you. Are there any questions? I have not managed any patients with COVID before, but I had one patient who was just 46 years old with diabetes. She was post-COVID two months, and she started having shortness of breath only after about 2 months, and chest X-ray is very suggestive of fibrosis. Now, I referred her to the respiratory physician, and she was treated with steroid, and she actually recovered both radiologically and symptomatically. So I want to ask you, if it's fibrosis, right? Do they recover with steroid post-COVID?
Okay. So as I said, of course, if you could biopsy the lung, that would be the best. But to biopsy someone, to convince them is not an easy thing to do. But I guess the least thing that you could do is get a high resolution CT scan. Okay.
I
So
did.
yeah, the high resolution CT scan, get a respiratory physician, or the best would be a thoracic radiologist, because they have the best. But unfortunately, there are not many in the country. Okay, we're fortunate in some way. We have a probably one of the best thoracic radiology in the country. That will make a difference. Okay, whether they will probably responsive to steroid or it doesn't. Okay. Traditionally, if it already fibrosed, it would not respond well to steroid. Okay. However, a lot of changes in the lung that are related to COVID will got better. Will got better either in time as well as if it, for example, remember I show you that the organizing pneumonia pattern. For some untrained eye, it may cause fibrosis, but it's actually not a fibrosis, a different pattern of organizing pneumonia, and organizing pneumonia responded well with steroid. Okay.
Okay. So another question I want to ask you, in the same patient that I saw, her rheumatoid factor was very, very high. Could it, the fact that she had
Could be.
rheumatoid,
Yeah, that's why it responded well to steroid.
so
Maybe remember that I said.
it brought about.
Remember I said that COVID may potentially, you have some underlying genetic predisposition. It was stable before, okay? Somehow with COVID, it triggered this potential, and they may accelerate lung damage, including interstitial lung disease. Okay, someone with rheumatoid arthritis, for example, if they develop interstitial lung disease, this interstitial lung disease quite responsive to steroid. So maybe this is something we call it connective tissue related interstitial lung disease.
Okay, we have a question here. The question is by Dr. Maiza. Does COVID affect the radial traction of lung? Okay, that one I don't understand. The radial traction of lung. You go to comment side, you can see the.
Okay.
So I don't know what is radial traction. Of lung.
Second.
Do you see it?
Yeah. Maybe radial traction. I mean, does it mean the lung being pulled inside?
Okay, Maiza, maybe you would like to, if you're still around, maybe you'd like to expand on your question, because both of us don't understand. But Farah has a question. Farah Akila asked, just want to ask regarding pulmonary embolism, if there any possibility can cause long-term complication as for now, even though already gone with treatment and management during active.
Okay. So, good question. And I do encounter numerous, multiple patients that has microthrombi as well as big pulmonary embolism in patient with COVID. I think the way we treat this should be based on our understanding of management of VTEs. Okay? So this pulmonary embolism is something that we know what are the causes factor, the causing factor. Okay, if you know what are the causes of this VTE, okay, and these causes we know that will get better, especially in COVID. It's common understanding that in 3 months all the inflammation will go down. Most of the lung function improve in majority of patients. So we know within 3 months, whether this 3 months is a fixed number, maybe no. Okay, so if we are treating pulmonary embolism, you know what's the cause, and the cause has been alleviated. I mean, the cause is no longer there. The duration of treatment is about 3 months, right? And cardiologists would also maybe agree with this. Okay, if you occur is unprovoked pulmonary embolism, you don't know what the cause, the treatment can be up to 6 months.
That's right.
The second, yes, right? So secondary,
First episode,
if
yeah.
you've got recurrent episode, then will be maybe longer. Okay, so but bear in mind that a small percentage of this pulmonary embolism may develop into a chronic PE. Okay, so having know that knowledge, I think in general, someone that has COVID, that we detect that they have pulmonary embolism, the treatment should be at least for 3 months. So at the end of 3 months, you have a choice. Either if they are well, you tell them you don't need to worry about it, anything, you just complete the treatment and say we don't need the anticoagulant anymore. Okay, this is true when I treat the patient, they have evidence of microthrombi. Okay, they don't have large vessel. So, and then after 3 months, they are well, their functions, the ECOG and everything is normal. So at the end of 3 months, I just stop the treatment and I don't repeat the CT scan. However, if you are still worried, I do have some patients even after 6 months, I feel breathless, doctor. I mean, my functional class is not good. And this patient, I may repeat, depending on how severe that their initial COVID, initial thrombose. So I'll probably repeat in Sunway, we have this VQ scan, which is more detailed that it can detect a microperfusion defect. Okay, so that's will tell me whether there are still some VQ mismatch. And on top of that, in Sunway, we also have dual energy CT scan, which also can detect lung perfusion even with CTPA. So I'm blessed with all these technologies that can help me manage my patient better.
Toys, the toys.
Yeah, toys, yes. Yeah.
Okay, I
So
want
yeah, to
a
cut the story
follow-up.
short,
Yeah.
3 months is adequate. But if you think that the patient may have underlying undiagnosed chronic pulmonary embolism, it may prolong the treatment. Okay.
Okay, sorry. On the follow-up on this question by on this pulmonary embolism, do you prophylactically give either NOAC or let's say a low molecular weight heparin for every
So
patient?
all patient category 3, which is you can see some changes radiologically. Remember that the post-mortem that we see a lot of microthrombi. So all patient category 3 and above, we will start prophylactic anticoagulant. The prophylaxis means that you give prophylaxis dose of Clexanes or low molecular heparin when during admission. Okay, and then those with category 3 and above, at the day 8 and above, we do a CTPA in some way. That's why probably the cost is a bit higher because we do just to see is there any potential pulmonary embolism that can be missed. Okay, because I have a patient that was hospitalized in the other center that came in on day 14 and turns out to be there's PE because it didn't have resource to do a CT scan. So if there is evidence of PE, we will give treatment dose. Okay, so anybody that are category 3 and above, this is in the recommendation anyway. Yeah? And then if there is no PE, when they go back, there is data or trial showing that a prophylactic dose of DOAC can be given up for 21 days to prevent occurrence of PTE. So
I
the
see.
dose, so for example, if you're using um, uh, uh, Xarelto, for example, is 15 milligram. We know that the maintenance dose, or actually the initial dose is 15 BD and then 20 OD, but we can give 15 milligram daily for 3 days for 3 weeks, or you can use Eliquis or Apixaban 2.5 BD for 3 weeks. Okay.
Okay. So Maisa has come back to us. She said that the radial traction is basically a traction between alveoli and bronchus, or attraction. Okay. Example in
Traction box. Yes. Okay. So it depends on it depends on the severity of lung involvement. If you develop diffuse alveolar damage, and if you are undertreated, this will progress into all the diffuse alveolar damage or ARDS. Got 3 phase. They can go into edema or exudative, proliferative, fibrotic phase if being unarrested and not managed properly, or even you manage properly, they have some predisposition. They may develop this fibrosis. Okay, it all started in the alveolar wall. The fibrosis will collapse the alveolar wall, and of course, this the fibrosis will cause a traction and tractions or traction bronchiectasis, which they will pull the airway and they become dilated. I guess this is the radial traction of the lung parenchyma causing traction bronchiectasis. So it can happen. I think that the term and causing is quite very specific in the area of the lung where it causes dilatation of the small airways. Okay.
So Maisa asked whether it's the only the alveoli affected. I think you have mentioned that many parts of the lung can be affected, even the endo.
Yeah, so lung we have alveolar, we have alveolar basement membrane, we got extracellular matrix, as well as the space between your the capillaries and your alveolar. That's the alveolar basement membrane. That thing is where the focus of fibrosis. And you develop highly membrane that cover the alveolar wall insides and causing collapse and fibrosis. So that's, and because the proximity, we always thought that we have airway to the end there's alveolar, but you always know that because the airway branch multiple times, so alveolar will always in close proximity of your airway, right? Especially your small airways, which you don't normally see in the CT scan because it's so small. But because of the alveolar interstitials, because that's where you call it interstitial lung disease, and the fibrosis happened there. So it will cause thickening of the membrane that not supposed to be seen. suddenly that you have fibrosis and causing the space that now you can see in the red in the CT scan, and it caused contraction and then pulling of the airway. Then the airway that not supposed to be seen in the CT scan, now you see, oh, there's airway, yeah, which is a bit distal part of the. So this is a very technical thing.
Okay, Sean asked a very interesting question. What's your take on statin improving outcome of COVID? And does it work?
New study say, I mean, there is a trial on statin and lung fibrosis. It doesn't work. Okay.
Okay.
I guess this is the thing that, you know, when a few days ago, a fluvoxamine that works in COVID, because they say there are some anti-inflammatory properties. Whether it work or not, I guess you really need to test it in RCTs. So I know that it doesn't work in lung fibrosis. Okay. So I guess we don't know until someone did a trial on it. Okay.
So this statin may not work on the lung fibrosis, but it improve outcome in another ways.
Probable. I mean, if you have the endothelial dysfunction, remember that it causes endothelial dysfunction.
Yes.
If I think you need to use such a high dose statin to improve your endothelial, right? Because I think this is you'll be in the cardiology realm.
I have a lot of experience with statin, but I have no experience whatever with statin with COVID or even COVID patients. I unfortunately or fortunately for me, I have not dealt with COVID patients. So Rebecca, yeah.
Yeah, the question is patient with PE. It depends on the patient. Okay, if someone is well, young, have no comorbids, they just got PE due to COVID, DOAC is enough. But someone, let's say, have a stent just put up 3 weeks ago, and then got PE, and then got COVID and got PE, I'm sure that if I stop the aspirin Plavix,
Oh, no, please
cardiology will be like bloody mad at me.
Yes,
right? So that's why this kind of patient, you be DOAC, aspirin, Plavix, because the mechanism to prevent of thrombosis will be different. So it individualized, is not one thing fits all. It depends on what are your patient comorbid.
Okay, this one I can answer somewhat, yeah, Rebecca. Basically, when you put in the stent, you have to use dual platelet and platelet therapy for at least 3 to 6 months, depending on what stent you use. And when you add a NOAC, doesn't mean that you take out your dual antiplatelet. Okay, basically, NOAC and every single anti-thrombotic or antiplatelet works at different pathways, and it all depends on the disease process. So for coronary artery disease, it's usually antiplatelet. For pulmonary embolism, we can use NOAC. Yeah, so.
Yeah,
okay.
True. I mean, if someone has stroke because of AF, for example, I think DOAC is adequate. But if you are dealing with a risk factor that require aspirin plus Plavix or aspirin or Plavix alone, the DOAC should not, replace them. So you should give DOAC as well as plus whatever needed for their underlying problem.
Okay, I think with that, we have done about 1.5 hours, just flew by us. So again, thank you very much, Rosmadi. It was a very, very enlightening talk. And as I said, quite a few people came in just at the end of the talk just to get the QR code. Next time, I will not admit these people. Okay, thank you very much. And I will see you. Oh, how do I actually stop share first? Yeah. Okay. Stop share. Okay. So I will see you at work the next few days. Okay.
Okay.
Thank
Sure.
you. Bye, guys.